Hi, I'm Dr. Álvaro Ordóñez from the Picos Institute in Tampa Bay. Would like to thank Dental XP for this kind invitation. I would also like to thank Carestream for making the presentation possible and for the high quality of their Combin CT equipment and their software, which we have utilized to put together the three-dimensional reconstructions for this presentation. The purpose of this presentation is to cover some aspects related to biomechanics of temporomandibular disorders, a little bit of management of parafunction and occlusion for natural teeth and implants, and basically we're going to try to get into the practical aspects of the diagnosis and management of these disorders. Our recommendation for today would be that we look at the textbook of occlusion of Dr. Moll, Sarp, Carson, and Roth, which is a classic, but it's still been an excellent book with the basic information up to date that we need on occlusal concepts. Also for implant biomechanics, the book to read is Contemporary Implant Dentistry of Dr. Misch. And I'm not going to recommend any specific temporomandibular disorder book. I would like you to get a little bit outside of that and probably consider reading a little bit more about muscles, muscle physiology, muscle activity. And a simple book, easy to read, that have been around for decades now is The Diagnosis and Treatment of Muscle Pain by Dr. Hans Kraus by Quintessence Editorial. Another book that is fairly recent is the Bruxism book, The Theory and Practice by Dr. Daniel Paesani, an Argentinian dentist that is a great clinician, great professor, a very thorough person. He did a great job putting together all the scientific evidence that is available in this topic. So it's an interesting book to read and to incorporate into your library. Our objective and our intention is to try to correlate the field of occlusion and merge that with the requirements, the occlusal requirements for a good dental implant reconstruction. So we're going to be looking at some interdental relationships. We're going to be looking at the maxillomandibular relationships and how these maxillomandibular relationships affect the craniomandibular system. We're going to look at function, dysfunction, and parafunction, and the mixture, the compilation of all these different aspects compose the field of biomechanics of the head and neck. We have to understand that it's very difficult to cover this in a short presentation, so basically pick your topics and then do your own research and your own reading at home. We all know that occlusion affects the position of the mandible, and mandibular position affects the biomechanics of the head and neck and upper quarter. Mehta and Forgioni have been working in this aspect, in this topic, trying to put together scientific evidence and research that have as a purpose the enhancement of dentistry as a science and as a field. We all know that implant occlusal design will affect the head and neck system, and that problems with the head and neck system will affect the long-term stability of the bone, implant, and prosthetic complex. The teeth, we all know that they have to work together, they have to coexist in harmony, and the actual interocclusal contacts will dictate the final mandibular position. That mandibular position has also to coexist with some bones, with some soft tissues, ligaments, muscles, and we're going to have some domino effects. And these domino effects are going to affect remote structures that are not necessarily dentally related. The big problem that we're having as dentists is that we got a dental education that was mainly related to the anterior-posterior position of this mandible, and we were educated to look at the anterior-posterior position of these condyles within the glenoid fossa. So we were educated to look at patients laterally from the front to the back. The reality is that we have to also look at the patient from the front because the mandibular position is not always centered, and lateral deviations of the mandible or actual torque of this mandible will create disorders. And if we don't identify these situations and if we don't address these anomalies, it's going to be hard for us to get into the right diagnosis, and it's going to be hard for us to create the right treatment plan for a patient. So when we look at the patient in a more comprehensive way, we're going to see that we have teeth interacting with the maxilla, with the mandible. We're going to be having a mandible that will need to have an interrelationship with this temporalis, with this temporal bone, and we're going to have to have an interrelation with this fossa. And when we look at this situation from the front of the patient in a more coronal manner, we're going to see that the mandible is going to have to be centered also laterally, not only anteriorly, posteriorly, which is going to become an issue with the frequent lateral deviations that we find in our patients. Not necessarily we're going to have patients having also the condyles leveled in the superior inferior aspect, because also these lateral deviations and the head tilts and the abnormal postures that these patients may present are going to affect the superior inferior position of these condyles in relationship to the horizontal plane. This is important because when we are going to reconstruct dentitions and we're going to reconstruct implants, we need to keep all these craniomandibular landmarks in mind to be able to create the appropriate occlusion and bring this whole system to harmony and stability. As dentists, our training in reference to the cervical spine and the different vertebrae of the neck has been very limited. And the reality is that there is a direct connection of this mandible to the hyoid bone and from the hyoid bone to the cervical spine. There is a great incidence in patients with parafunctional disorders. There is a great incidence of elongation and calcification of the styloid processes. And as dentists, we usually have the tendency to try to identify or try to correlate these to potential Eagle syndromes. The Eagle syndrome incidence is actually very low, but the elongation and calcification of the styloid process is very high in patients with parafunctional disorders. When we look at mandibular positions and we look at interdental contacts, if we add not only muscles and ligaments, but we also add the soft tissues and the impact and input of the neuromuscular system, we're going to understand that occlusion and TMD management is more complicated than just thinking of condylar position and interdental contacts. It's a whole complex that we need to try to understand to be able to actually get to the proper diagnosis, treatment plan, and long-term management of our patients. So it's very frequent to find patients that are presenting neck-related issues because of a poor interocclusal setup and because of a poor mandibular three-dimensional position. And we see that when we put this mandible back in place, the first symptom that usually have the tendency to evolve in a positive manner are the neck-related symptoms, which is an interesting aspect, having in mind and considering that we are dentists and not orthopedic physicians. And this brings another interesting topic, because basically we have been trying to treat an orthopedic problem with dental strategies. Edentulism and TMJ is mainly an orthopedic problem, it's not a dental problem. So we need to actually look at this situation from a different perspective. And this concept is actually a concept that I heard for the first time in a conversation with Dr. Steven Feldman, and actually it became clear that he had noticed also that there is a strong relationship between neck-related problems, shoulder-related problems, and poor mandibular positions and poor interocclusal contacts. We can observe over here, for example, in this patient, a lateral deviation to the left side, and how this condyle is a little higher on the left side than on the right side. And the question would be, what can we do about it to be able to bring this mandible into the proper position? Because this is a difficult situation to actually manage, especially in a patient in which we're going to have to fill in some spaces that are missing because of some teeth that were extracted. So as the teeth were extracted, these teeth that were holding the mandibular position were not there anymore, and this mandible was able to shift to the left side. And now, in the process of reconstructing, we need to understand that part of the treatment is not just to fill in the missing teeth, to fill in the gaps, but also to try to put this condyle back in place. This invasion of the joint space that have been created by this condyle for sure have created an effect on the disc, have likely created an effect on the cartilage, and very likely have induced to some remodeling of the hard tissues in that area. But also the soft tissues that are accessory tissues like the muscles and the ligaments in the whole system has suffered, because once you have this migration to the left side of that condyle, then you're going to have an effect on that hyoid bone, and there's likely going to be an impact in that hyoid bone position, or at least in the way that the forces or the physiology of the muscles and ligaments that are interconnected in the suprahyoid regions and infrahyoid regions, and the performance in the physiological manner. So these are situations that we need to understand specifically when we are dealing with patients that are completely edentulous, fully edentulous, or even patients that are missing a segment or a group of teeth. Then we have to understand that this hyoid bone is also connected to the scapula, and there are soft tissue connections to the cervical vertebrae and to the base of the head, of the cranium. So let's think about all this situation, because if we think of the fact that restoring teeth is going to impact the mandibular position, and it's going to put the mandible in a more open situation or more closed situation, is going to bring us to the fact that when we have more vertical dimension or less vertical dimension on a given individual, these hyoid areas are going to be having an effect. And the question would be, how much should we open the vertical? How much should we close the vertical? How forward should be positioned the mandible, or how backward, so we can actually have a physiological position for this hyoid bone, and therefore an effect to the accessory structures that are connected to it. Because think about it, we have very, very strong muscles, and these are postural muscles, and these are muscles that actually are deeply involved in function, and can also be very involved in parafunction whenever the mandible needs to do a specific action. So think about what's going on at the neck level, what's going on at the posterior cervical level, what's going on at the head level whenever we are creating or designing occlusions and working with dental implants. It's very important to keep in mind that the position of the mandible is is in close relationship with the actual position of the first and second cervical vertebra, and that deviations to the left side or to the right side, or even to the front or to the back of that mandible, will affect the actual position of the vertebrae. Also, vertebral rotations will have a direct effect on mandibular function and will probably create a tendency to have some type of parafunction. So one of the interesting aspects that I have noticed whenever I send my cone-beam CT images to be evaluated by my radiologist is the fact that they are not looking at the position of the vertebrae. They don't look at the cervical vertebrae in the sagittal aspects. They don't look at the cervical vertebrae in the coronal aspects, and they are not looking at the cervical vertebrae in the axial aspect. And it's an important source of information that we are missing because probably we are not aware of that relationship. But for craniomandibular disorders, for maxillomandibular reconstructions, it's important to have a stable first and second cervical vertebrae because they have a direct impact on occlusion, and vice versa. Occlusion has a direct impact on the actual position of these vertebrae. This type of deviations or luxations or subluxation of these vertebrae are patients that are going to eventually get implants, blocks, sinus elevations, all kind of different dental procedures that are going to be performed in an occlusion that is not a stable occlusion, because once we have that rotation of those vertebrae, or once we have mandibular rotation, we're going to have a situation in which these pathologies are going to fit the different systems. The neck-related system is going to affect the mandibular system, and the mandibular system is going to affect in a negative or even positive way the cervical system. So keep in mind that we need to be able to look at the big picture, to be able to give our patients the best, most comprehensive type of implant-related reconstruction or even natural dentition reconstruction. So it is important to have a clear understanding of what are we going to evaluate and how are we going to do that evaluation. So the basic concepts of dental occlusion remain up to date in implant occlusion. It's important to understand that the concepts of basic occlusion, universal occlusion remain the same. We need to have clear concepts of what condylar positions are and what condylar positions are we going to be working with. We need to know and have a solid understanding of what is an occlusal plane, what is the curve of SP, how are we going to reconstruct or recreate that occlusal plane in the proper way, how are we going to reconstruct or improve that curve of SP, what is the right overbite and what is the impact of having too much of an overbite or not having an overbite at all, what is the right overjet and what is the implant of having too much of an overjet or too little of an overjet, what is the right vertical dimension of a patient. And the vertical dimension is one of the big fallacies in implant dentistry and in dentistry at all. There is no specific technique that would bring a patient to the appropriate vertical dimension. And vertical dimension is mainly recreated by feeling. That's the reality. There's no specific technique to bring somebody to the right vertical dimension. Some people agree that vertical dimension is not a set position, it's most of a range. And since we tend to lose vertical dimension throughout our life, it's better to work in the longer ranges of vertical dimension rather than working with a short range of vertical dimension. So vertical dimension is something that I would like to see people giving to their patients, and understanding that it's always better to give a little extra vertical dimension than being too tight in the vertical dimension that we give to a patient. The anterior guidance is another important concept, and it's very, very important not to confuse an anterior guidance with an anterior fence. In the process of creating an anterior guidance, very often what we end up doing is creating an anterior fence that will restrict mandibular function and will restrict mandibular dynamics and will act as a fence for mandibular motion and will create problems for these patients, and the patients eventually will start clenching against that anterior guidance that wasn't really an anterior guidance. So it's important not to invade the envelope of function of a patient in the process of creating an anterior guidance. We need to understand that some patients are going to work in group function, and we need to make a decision whether we're going to work with that patient in group function, or if we're going to work with a canine guidance, or even if we're going to restore this patient in a balanced occlusion kind of a setup. We need to have a solid understanding of what is parafunction and what are the different kinds of parafunction that a patient can present. We find all these different concepts in the textbook of occlusion of Dr. Moll, Sarp, Carson, and Roth. Now, if we're working with implant patients, we need to bring 4 additional aspects to the equation. One aspect would be related to the implant. What kind of implant design are we going to utilize? What kind of implant diameter is the right one for that specific site and why? What kind of implant length? What kind of surface are we going to utilize? And what kind of angulation are we going to give to our implant? What kind of bone height are we going to create? Are we going to work with the given bone height, or are we going to enhance that height? Are we going to enhance the width, or are we going to work with the width that we have? Are we going to work with physiologic bone tables, or are we going to push it and have very thin bone tables? Because remember that the bone tables are going to have a specific relationship to the soft tissues that interact with that bone. Do we have the right bone density to hold that implant in place and support the load that that implant is going to be subjected to? How much surface area do we want, and how much implant load do we really want to give to that specific reconstruction? What kind of occlusal span are we going to build into a restoration, and what kind of occlusal table? We're going to have some stress, there's going to be some deformation and strain, and there are going to be loads definitely. So how are we going to make everything work together on behalf of that patient? So it's important to understand that there are aspects related to biomechanics, there are aspects related to anchorage, there are aspects related to centric and eccentric stability, and all these aspects are integrated and need to be integrated so we have a nice physiologic functioning of the craniomandibular system. We can find information about these concepts in Contemporary Implant Dentistry, the book of Dr. Misch. Occlusion will affect grafting, and grafting will affect occlusion. And this is probably the best way to look at that type of situation. Let's look at a patient on a cross-bite type of setup. If we have a patient that was on a cross-bite and that patient lost a specific tooth, we need to make decisions. Are we going to try to bring that cross-bite into a normal bite? Are we going to end up in an edge-to-edge type of bite in the process of trying to make changes in that specific ridge? Or can we actually graft, probably expand those tables and try to remodel that specific interocclusal relationship, bringing that cross bite now into a normal bite? Because we have to understand that this type of a specific decision and this type of a specific situation is going to have an impact in that site. It's going to affect the interocclusal contacts. It's going to affect the physiology of the soft tissues and the hard tissues. And we need to understand what we're doing and why are we doing it, and we need to know if we can actually do it. This is a specific example of a patient with over-eruption and very limited interocclusal space, and how to do that management. Are we going to probably put implants and place crowns that are below the occlusal plane, that are not helping to recreate a good curve of a speed? Because the right way would be probably to remodel those teeth that are in over-eruption, or to even extract them or to probably do root canals and put crowns. I mean, the strategies are to be made by you, but you need to at least identify the problem, identify the situation, and try to bring a situation like that into a more physiologic type of interocclusal relationship. So basically, the whole idea would be to be able to make that removal, place, for example, those implants, and try to create teeth that would not be looking like a hammock. Probably teeth that would be having a more physiologic type of interocclusal relationship. So this is an improved occlusal plane, this is an improved curve of SP, and this is an improved interocclusal setup that will eventually affect this patient in a positive manner. Because this was a patient that actually came to our practice because of having headaches, not because of wanting to fill in the spaces. This patient didn't come for implants. This patient came for healing of some symptoms related to the head and neck. So the plane of occlusion, the vertical dimension, the midline, and the curve of SP will define your occlusal modifications. We need to be very aware of the actual positions or mispositions of these different concepts of occlusion, and we need to be able to make an early identification, and we need to decide if the specific case requires that we do modifications to the interocclusal setup. So when we see situations like this in the lower right side of the screen, we're going to see that this is not the best setup of an occlusal plane, and this will affect also the plane of occlusion, and we're going to need to make some modifications to be able to have a patient that is going to have better function, going to have better mandibular displacements, and a patient that is likely going to have better dispersion of forces. So always evaluate your plane of occlusion, always look at the vertical dimension, always look at the interocclusal contacts, look at your midline, and remember that there are two types of midline. You have the dental midline, which is easy to be moved with orthodontics and even prosthetics. And there is the skeletal midline, which we usually use the frenum as the landmark to decide where that skeletal midline is. So it's important to look at that midline and establish if the midline is centered and if the dental midline coincides with the skeletal midline. Because if the dental midline and the skeletal midline are out of place, we know right away that we have a lateral mandibular deviation, and we need to do something about it if this patient is a patient with symptoms. So at this point, once we have done the identification of the anomalies, we need to decide to make the corrections. And these corrections depend on the kind of problem that we have identified before. So some of those problems that we're going to find are going to likely be over-eruption, and that over-eruption is going to affect the restorative space, but it's also going to affect anterior-posterior movement of the mandible because the over-erupted teeth, let's say over-erupted in the maxilla, anytime that we try to do anterior-posterior movements or posterior-anterior movement with the mandible, we're going to be hitting on that over-erupted tooth, and the mandible is going to have to try to avoid that specific obstacle. The poor curve of SP will create a similar problem, but it's also going to contribute to potential lateral deviations of the mandible. Canted occlusal planes are very problematic and also are related to lateral displacements of the mandible. Initially inclined molars, especially in implant dentistry, and premolars need to be addressed from the very beginning, and sometimes we need to do preparations to prepare that specific site for the coming implant and restoration. The poor vertical dimension is a big problem that affects the head and neck system. The midline shift, as I mentioned before, will affect also our patients and will be related to many of the symptoms that our patients present related to head and neck problems and TMD disorders. The distalization of the mandible happens in patients that have been losing vertical dimension or the posterior segment, the molars and premolars. The mandible tends to fall backwards, and the condyles seem to get positioned more upward and more posteriorly. And that also become an issue because the actual components, anatomical components of that joint start getting remodeled, and sometimes the body can remodel, but sometimes the process will exceed the ability of the body to get that remodeling process, and then we're going to have problems. The question would be, do we always have to make these corrections? And do we always have to bring the patient to perfection? Because another thing to keep in mind is that patients with temporomandibular disorders or with occlusal disorders sometimes require a very minimally invasive dentistry. So we need to use wisdom. We need to have a good input in the process of making our clinical decisions. So when we think of occlusion, we need to think of the appropriate three-dimensional mandibular position that we want to either maintain or restore. We need to think of having mandibular movements that are efficient. We need to think of having an appropriately set up dentition. We need to be able to restore or maintain our planes of reference. And we need to understand that the occlusal concepts exist for a reason, and we need to be able to apply these concepts and incorporate occlusal concepts into our restoration. This is a classical example of a patient that is going to lose two teeth, and today we are doing digital setups utilizing STL models that are interposed or interconnected with the Convin CT images, and this is a virtual setup utilizing the software. And we have been able to recreate the upcoming restorations. The extractions are made and the site is grafted utilizing a socket preservation technique, trying to enhance the site. And we can observe the aggressive destruction created by the parafunctional habits of this patient. This patient is not just a grinder, but is also a clencher. He rubs the teeth constantly, and he also applies sustained forces, and he has been created multiple problems to his dentition. He has lost vertical dimension, the mandible have gotten displaced, and it's very hard to actually correct each one of the problems on a patient like this when the patient is, number one, limited in resources, number two, has come to the practice to take care of the two teeth that he's now have had extracted. So this is the kind of patient in which utilizing splint therapy becomes a great treatment option, because it's the kind of patient in which we're not going to be able to do the most comprehensive type of treatment and probably reconstruction. So at least utilizing splint therapy, we can delay the damage and we can slowly try to intercept the problem that is going on with the patient. But this patient is coming for now implants in the areas in which the extractions were made, and these implants require a very careful and thorough planning, because this implant needs to have the right diameter, the right length, the right angulation, and the right restoration, because we know that they are going to be subjected to heavy forces. So in these kind of cases, doing a virtual plan becomes a great way of planning in the patient, and it doesn't get any more realistic than interposing the scan with the STL models of this patient. Part of the process that we can do today is utilizing a virtual evaluation of occlusal function. And this is an interesting function of the 3Shape software, in which we can actually mount our models on a virtual articulator, and we can even choose the type of articulator from a series of articulators that are being offered by the software. And then we can organize that occlusion, and we can study the occlusion in a static way and in a dynamic way. And by doing that, we know exactly the type of occlusal setup that we're going to build into this specific patient. So virtual evaluation of occlusal function becomes today a reality, and if done properly, becomes a very realistic way of evaluating and studying occlusion. So now that we have been able to create the right treatment plan, or the best treatment plan that we are able to select for this patient, and at least from the implant standpoint, we proceed to actually prepare the site, and this is a guided surgery process, and wide implants, long implants are placed to be able to reconstruct this patient and bring this patient back into having his teeth, and also after this situation is done, a new spleen is created for this patient. So we need to understand that we have the option today to create the implant occlusion virtually, and we need to incorporate concepts like the concept of Dr. Rosenfeld and Dr. McCall and Dr. Ahmed and Dr. Gans, in which basically they suggest the utilization of splints that have radiopaque media for the scan process. So during the scanning of this patient, we can be utilizing treatment acceptance prosthesis, in which the patient is going to get an excellent idea of how the occlusion is going to be like, what the cosmetics are going to look like, and at the same time, we can utilize them for TMD related purposes, and even to guide the surgeries. So it's important to create models, whether these are physical models or virtual models, in which we can actually set up our occlusion and make sure that the occlusion is following the classic rules and the classic laws of occlusion. So it's called a setup. A setup is important because that setup can actually be recreated and converted into pens and springs and devices that will guide our treatment. And even this setup can be interimposed with the upcoming implant virtually to be able to get an idea of where the platform of that implant is going to be placed, the abutment and the abutment color, and all this is going to have a direct effect not only on occlusion and function but also in cosmetics. So if we plan the cases carefully, and if we plan the cases utilizing the available technology, we're going to be able to actually perform an implant dentistry that is going to be very superior than doing the implant dentistry just guided by our eye at the time of the surgery. Each surgical guide and each surgical stent should be able to fit perfect. If it doesn't fit perfect, you can try to reline the device. Once you have good fit, it's the right time to scan the patient. And you can see in this specific patient how we have been able to recreate the occlusal plane and the actual curve of speed up to a point, because we cannot see the whole process. But it's an excellent way to work. It's an excellent way to get an idea of what the occlusion is going to look like. It's going to give us a solid idea of what kind of modifications are to be made in the antagonist, and we are going to avoid surprises. The patient can be informed right away of any kind of treatment that needs to be considered to bring this case to the right completion. Virtual occlusion today can be done with different softwares and with different type of strategies. We can actually virtually plan implants, we can virtually plan grafts, we can virtually plan abutments, and these abutments can be realistic abutments. We can plan the occlusal table of an implant, the anterior posterior size of a crown. We can plan the facial lingual dimensions, the superior inferior dimensions. So today we can virtually plan almost anything to be able to perform our procedures as planned. The SDL models, the actual optical scanning, becomes a great tool for occlusal planning and occlusal diagnostic. We can actually today scan models, or we can even do intraoral scans, and we can utilize that information to examine the maxillomandibular relationships of patients. We can also use it to evaluate occlusion, to evaluate implant site, and to make our implant selection and implant diameter. So this is the same patient that we saw before, but this is the opposite side. This patient was walking her dog and she had an accident when the dog started chasing a cat. And we basically removed the old bridge that she had and put a temporary bridge. And from the very beginning, we tried to perfect those interocclusal relationships. And then we were able to scan the patient with the temporary crowns and without the temporary crowns. And we were able to actually start examining that occlusion in those three-dimensional models. And these are the temporary crowns that we made. These are the two areas with the crown preps. And now we also have the soft tissue information of this patient. And if we utilize the transparency mode, we're able to overimpose the two SDL models, the two scanned models, and now we are able to decide where we want the implants and decide the diameters of those implants and even the lengths of those implants, the abutments, the angulations, and this is going to help us perfect our case. Today we have the ability of printing models in our practices if we have printers, and they become very handy for surgical planning and occlusal planning, because we can actually see printed models duplicating dentures and duplicating different dental devices. And this is part of the armamentarium that we're utilizing now to be able to design an occlusion and get an idea in advance of how the patient is going to look like, how the patient is going to feel with the new upcoming dental work. And this changed the whole equation, and it changes the whole game of how dentistry will be in practice. We can then get to work with the patients, perform our surgical techniques or whatever kind of dentistry we need to do. We can utilize computer-guided processes and techniques to be able to deliver the best type of implant dentistry that we can possibly make. The problem is that when we know that we have forces and when we know that those forces are active and we don't do anything, then all we have to do is hope that our dental work survives. And that becomes a problem because then we are losing predictability in our work. And we're going to have to get to see this patient more often and get to repair problems. It is a fact that forces will affect the implants. And it is a fact that forces will affect any type of dentition. The forces can overcome the strength and the resistance of any dental material. And it's very important to understand that those forces are going to travel to the implant and to the bone surrounding the implant and can create a negative impact. So one of the things that we like to do in our patients, because our practice is a TMD practice and our implants are done on patients with TMD disorders and with parafunctional habits, is the fact that after placing an implant or doing any type of implant reconstruction, our patient is getting a splint. Most of the time, the patient is getting an stabilization appliance if he's not symptomatic. In a symptomatic patient, we need to do different strategies. But most of the time, the stabilization appliance is going to be our workhorse, and it's going to be our first choice of a splint that we're going to utilize to protect the new restoration, to protect those implants, to disperse those forces, to protect the teeth of the patient, the TMJ, and the muscles. Because this patient is going to continue having likely parafunctional activities. A common problem that we have to face in our practice is the fact that many of our patients are missing the posterior segment, and restoring the occlusion in the posterior segment and rebuilding the posterior segment can become an issue. So, one of the things that I want you to understand is the fact that in a natural dentition, you're going to find patients with normal forces and patients with parafunctional forces. Those normal forces can have a short duration, low intensity, but if we have parafunctional forces, we know that we're going to have long duration and high intensity. And that becomes an issue because in normal forces, life is beautiful. You can do any kind of dentistry that you want. But whenever we have patients with parafunctional forces, we have the potential of having destruction and damage of the dentition, and even destruction and damage of the dental work that we have delivered. So the important thing to do is to recognize and manage these type of situations early rather than later. So we always want to prevent and or delay damage to the dentition and to the dental restoration. We want to disperse the forces, or we want to eliminate or reduce the forces, or the combination of both, disperse the forces and also eliminate or reduce the forces. How do we do this? We do it utilizing splints, remodeling the occlusal design, building protective schemes for occlusion. We can utilize biofeedback. We can even utilize medications like Botox. But if we don't do anything, we're going to have destruction and damage, and we're going to have to repair those situations, and it becomes a big issue. And it's exactly the same type of approach when we're dealing with implant retained teeth. Exactly the same situation. We're going to have normal forces, we're going to have parafunctional forces. Now, a patient with normal forces can become later on a patient that will have parafunctional forces. We never know. So it's important that always, when we're building an occlusion, when we're doing restorations, that we keep in mind that even though the patient might not be subjected to parafunctional forces, it is something that can happen in the future. The pain and dysfunction happens when three factors come together. Anytime that we have predisposing factors, precipitating factors, and perpetuating factors, we're going to have pain and dysfunction. And it's very important to understand that we break the cycle by breaking the factors. If we eliminate those predisposing factors, or the precipitating factor, or all the factors mentioned before, we're going to be able to bring that patient back to normal function. So there are different clinical scenarios that involve patients with missing teeth, abnormal occlusion, and forces. Because what we need to understand is that the forces might be acting now, might not be acting now, or might be present in the future. So we need to divide the universe of patients in three types of patients. We have the normal patient, we have the patient with occlusal disorders but no symptoms, and we have the patient with occlusal disorders and symptoms. And we need to understand that the patient with occlusal disorders are going to usually have oral collapse. Some of them are going to have loss of vertical, destruction of crowns, pathologic migrations, and pain and dysfunction. And we need to understand that these patients are likely going to lose their three-dimensional mandibular position. The big question would be, how did that implant patient become an implant patient? Did the patient become an implant patient because of poor hygiene? Or did the patient basically destroy their teeth because of parafunctional disorders? Did the patient have a car accident or any kind of trauma? It's important to understand where did the implant patient come from. So again, that normal patient, when treated by you, consider the possibility of creating an implant protective occlusal design. You don't usually have to do any kind of correction to this patient, but it's very important to try to build restorations that are keeping in mind the fact that in the future, parafunction could be a reality. So plan for possible future parafunction when doing your dental work. The patient with occlusal disorders and no symptoms, it's important that during the dentistry try to correct those occlusal imbalances, and hopefully introduce an eye guard as a protective mechanism. So again, you are planning for possible future parafunction. And then you have the patient with occlusal disorders and symptoms. And these patients you need to treat. You need to treat the symptoms. You need to eliminate pain. You need to restore function. And if this patient needs implants, you can place the implants and leave them alone. Let them integrate, full integration of those implants. Leave them there for a long time. In this patient, you want to place a strong and excessive anchorage. You want wide, long implants if possible. You want multiple implants because you know that these patients are going to be creating forces that will eventually travel and be dispersed to your implants and implant restorations. So, biomechanics and parafunction affect your case design because in the normal patient or in the patient with occlusal disorder or even the patient with symptoms, you are going to understand that you're not going to be able to do the same type of treatment designs. The normal patient, the patient with a parafunctional habit, is likely the patient in which the all-in-4 type of treatment will be successful. But if you do all-in-4 in a patient with heavy occlusal disorders and symptoms, a patient with heavy parafunction, these 4 implants are going to be under a lot of harassment, and they are likely going to have more chances to fail. The normal patient, the patient without parafunctional habit, is the patient in which immediate loading likely going to work well. You don't want to immediate load that patient in which you're having parafunctional habits. So you need to think, are you going to help yourself with splints anytime that you are doing this type of restorations or not? Because the splints will always help you to disperse forces and balance the bite. The patients with occlusal disorders and symptoms are patients in which you need to build stronger foundations, more surface area, probably build that implant protective occlusion that Dr. Mish talks about so much, and you always need to finish this patient with splints. And I advise you to do the same on the patient with occlusal disorders and no symptoms. There are 4 key factors during treatment planning and loading decisions. The first one is identification. If the patient have occlusal disorders and parafunctional forces, do an early identification. Examine the patient and look for that. Number 2 would be differentiation, and differentiation would mean what kind of occlusal disorders and what kind of parafunctional habits. Is the patient bruxing? Is the patient clenching? Is the patient biting his or her nails? Is the patient doing abnormal movements of the jaw? Is the patient going into crossovers? It is important that once you identify and differentiate, you make a plan so you can recondition that system, and then you make a plan to keep a long-term stability by protecting that system. The question would be, when do you do all this? Do you do it before? Do you do it during the treatment, or do you do it after the treatment? It's better to get in there early. It's better to try to address this type of situations from the very beginning, from the very first appointment, and make the patient aware. So try to recognize the presence of those forces, try to differentiate the kind of forces, and try to recondition the system and protect your dental work. And there are different kinds of parafunctional habits. Very important to do the clinical identification, and the clinical identification is done listening to the patient, doing your palpation to the muscles, and looking at the clinical evidence. On the other hand, you can also utilize the radiographic evidence by looking at the periapical x-rays, for example. The widening of the periodontal ligament is a factor that we use all the time. We can look at the panorex and we can look at the combing CT. When we look at the panorex, look at the size of the coronoid process, for example. Look at the width of the coronoid notches. Look at the angle of the mandible. Look at the presence of osteophytes or flattening of the condyles and or the eminence. Look at the styloid process and check if you're having elongation or calcification. There are different factors that will let you know that there's something going on, and there are factors that will allow you to know that things have been going on for a long time or for a short time, And this is important clinical relevance information. So again, it's important to differentiate the type of parafunctional habit because that will affect the type of treatment and therapy that you're going to be utilizing, especially if you are incorporating splints into the treatment. It's important that you have different strategies to protect your work and to protect the dentition of the patient. One strategy would be to utilize splint therapy, and there are many different kinds of splints. Another strategy is to have the patient go into biofeedback training. Medication can be very helpful in some patients, and it's important to get the patient involved and have a compliant patient that is willing to help us for the long-term management. We like to use splints for prevention in patients that have predisposing factors. We like to utilize splints to confirm our diagnosis or to lead us to a diagnosis. We can utilize splint to eliminate signs and symptoms, so it's a great therapeutic strategy. We can utilize the splints to guide our treatment. We can utilize high precision guides in restorative, orthodontic, and surgical treatment. And there are different kinds of bite plates. And these bite plates will work with different concepts and different strategies for condylar position. You need to become familiar with more than one design, hopefully, and you need to be able to recognize what would be the right modification that the splint would incorporate into this patient craniomandibular system to be able to have the patient evolve positively. So, the lower stabilization appliance, it's an excellent appliance that can be utilized to treat symptoms, but also as a protective mechanism. If you feel more comfortable utilizing the standard stabilization appliance, the Tanner appliance or the Michigan appliance, that's a good strategy too, but again, you need to make a decision of why are you using what. But this is just to show you a different type of appliance, and it's important that you understand that there's not just a single appliance there, because most dentists have been trained in specific stabilization appliances. There are so many designs that have been created for different purposes and different reasons. A good splint should always have stability in centric. It should be stable in eccentric movements of the mandible, and it should be adjusted periodically because occlusion is not static. Occlusion is dynamic and it changes. And it changes depending sometimes in muscle activity and muscle physiology. So it's important that you keep on adjusting and evaluating your splints. Medication is always good to have some alternative, and most of these patients have high levels of anxiety, and sometimes we need to use medication for anxiety or medication for depression or muscle relaxants. Diazepam can be an excellent muscle relaxant. Flexeril can be an excellent muscle relaxant. Scalaxin, Robaxin, there are so many out there, and we could probably discuss dosages in a different presentation. Sometimes we need to utilize medication for pain, medication for inflammation, and a great medication that I really like to use in TMJ that we incorporated about 12 years ago into our practice is the application of Botox in TMJ and also in implant dentistry. It's a great adjunct therapy in immediate loading, for example, to decrease applied forces, and it's also a great therapy to relax masticatory muscles in the TMJ patient. So basically, Botox is a toxin that inhibits the mechanisms for the release of acetylcholine. And the whole idea is to reduce forces, to reduce muscular volume, to reduce the intensity of parafunctional habits, to reduce the frequency of the habits, and to reduce the strain that these forces are creating to the joints. In immediate loading, for example, the whole idea would be also to make all these reductions so there are not so many forces, so often so strong, affecting the actual temporary crowns that have been immediately placed into the implants. How does it work? We basically have three proteins, the BAMP2, the SNAP25, and the syntaxin 1A, and when they get together, there is acetylcholine release. The whole idea of using botulinum toxin is to prevent that one of these three proteins gets to the actual synapses and allows the release of the acetylcholine. And by doing that, there's no muscle contraction. So the brain is basically sending the message to the muscle, but the muscle is not being able to actually perform the action. We can use it in implant dentistry for parafunctional habits, for trismus, for gummy smiles, superior and inferior gummy smiles, and for different type of facial cosmetics. Just think about those patients in which you do, for example, a graft, and the patient is healing, or even the graft goes south, and you have issues, and every time that the patient smiles, is showing metals and is showing graft-related materials, you can actually avoid that lip from being elevated or being depressed, and the patient is going to have a more cosmetic period during your implant-related treatment. In TMJ disorders, we utilize it in different areas of the head and neck, and even in the upper back. And the whole idea is to create muscle relaxation to these patients, decrease the forces, decrease the intensity, the duration, the power that the force that these patients are putting into the condyles or the muscle contraction. And it's been a great action. It's probably have been the best medication that we have incorporated into our practice in the last 12 years for TMJ disorders. So a good combination of spleen therapy and a good management of Botox can make a lot for a patient. The right strategy and the right technique is to utilize the concepts and techniques of Janet Travell to treat the trigger points, and instead of using saline solution or Marcaine or Carbocaine or Procaine, utilize Botox, and that will make the biggest difference in the treatment. And this is a patient that was having some problems during her implant treatment, and basically we were able to depress that lip so she wouldn't show the actual graft and the actual areas that were undergoing the work. To do that, to depress that problem, you need to select to select the lip or to relax the muscles. You need to select the right area. You need to understand muscle physiology, because remember that muscles contract to their origins, and if you understand that physiological principle, you're going to be able to do whatever effect that you want utilizing that Botox. So to conclude today, it's important that you always keep in mind that you need to identify the pathologies of your cases. And once you identify the problems, try to plan in a careful manner. Become very knowledgeable in different strategies and techniques to reorganize occlusion, because you're going to have to manage forces. You need to learn to deal with the collapsed dentition. You need to learn to open the vertical dimension, raising very often the molar areas, and you will be able to have a space for anterior crowns in many cases in which you need that space but you don't have it. You need to be able to maintain that system in good shape. Very important also, you need to learn different strategies for force dispersion. So try to get familiar with the utilization of splints and the application of Botox. It will help you with your implant dentistry, and it will help you with the forces, with the management of the forces. And again, I want to thank the Picos Institute, Dental XP, and CareStream for having the opportunity of covering this topic in a very short period of time. Hopefully you're going to be able to take some of this information home, and you're going to be able to expand on your own, obtaining the right books and attending the right courses to get more familiar with this very interesting but very daring area of dentistry. Thank you very much.